Today we are going to discuss the nursing management of patient with febrile neutropenia. Aim of the presentation is to provide an overview of the treatment and implication of febrile neutropenia. Learning outcomes are examine the literature in relation to febrile neutropenia to highlight the importance of the nurse's role in the management of patients with febrile neutropenia, to generate more knowledge about the potential life-threatening implication of febrile neutropenia and the importance of rapid treatment. Patient is Mary, 42-year-old lady, referred by GP in April 2011, and she noticed a lump in her right breast and lump present for a week, no other symptoms. Her previous medical and surgical histories are asthma, cesarean section times 2, and she is on current medication, seretide inhaler and singular. Her social history is she is married lady with 2 children aged 7 and 3, working as a care assistant in a nursing home, and her ECOG score is 0. Diagnostic workup. History and physical examination shows palpable upper outer quadrant mass. Blood works, full blood count, renal, liver and bone tumor markers, CA 15-3, mammogram, ultrasound, core biopsy, sentinel node biopsy, and PET scan. Diagnosis. Histology shows stage 2 adenocarcinoma, that was invasive ductal carcinoma. Tumor size was 2 cm, T1N1M0, ER negative, PR negative, and HER2 negative. CA 15-3 is 50. Treatment modalities are May 2011, she underwent wide local excision with clear margins and lymph node dissection. July 2011, she had 4 cycles of AC regime, which is doxorubicin and cyclophosphamide every 3 weeks, followed by 4 cycles of Taxol every week. She had echo and mucus scan, and also she had radiotherapy post chemotherapy. She had low mood and depression, and she underwent psych oncology referral. She didn't had any adverse reaction when she attended the oncology day ward for the first cycle of chemotherapy, and the public health nurse to administer the Neupogen 24 hours post the chemotherapy. Potential side effect of AC regime. Doxorubicin side effect are myelosuppression, cardiotoxicity, vesican, nausea and vomiting, alopecia, red urine, infertility. And the side effect of cyclophosphamide are myelosuppression, hemorrhagic cystitis, nausea and vomiting, hyperpigmentation of skin and nails, alopecia and infertility. Her actual problems start on day 8 post chemotherapy. So Mary presented to the A&E department with a temperature of 39 degrees centigrade, accompanied by her husband Mark, delayed in A&E due to road traffic accident, and she was Riegering. Her vital signs were checked, her blood counts were checked, so FPC was done, renal, liver, bone was done, and CRP was done. Peripheral blood cultures were taken. She was started upon tazocin and gentamicin, and pethidine was given for rigors. She had her chest X-ray. She admitted to oncology ward. Her neutrophils were 0. Febrile neutropenia is defined as a neutrophil count less than 1000 per mm. A febrile neutropenic episode was defined as an axillary temperature more than 38.5 degrees centigrade once, or more than 38 degrees centigrade on 2 or more occasions during a 12-hour period. So we need to discuss in this what is the time from triage to antibiotic administration and its impact on patients' outcomes. How can nurses reduce the risk of febrile neutropenia? So we used a Canadian study, quantitative study, which includes 68 patients present with febrile neutropenia to determine the time from triage to antibiotic administration and its impact on patient outcome. This was done in Regional Health Authorities Emergency Department. The results are 76% of patients were seen in tertiary care centers, 65% of these patients were triaged to be seen within 15 minutes of arrival in the emergency room. Median time to reassess was 57 minutes. Time from triage to antibiotic administration was 5 hours. No increased risk of death or increased length of hospital stay was associated with the delayed antibiotic administration. Reason is multifactorial. Need for standardized protocol to direct the flow of people with febrile neutropenia through A&E. Patient care could be improved by implementing various strategies to shorten the time from triage to treatment. Protocolizing A&E care and producing a care map for various vulnerable patients would streamline their care and provide a framework for A&E staff in managing an uncommon emergency department event. So we used a Korean study which include 102 patients, outcome in patients that present to emergency department with chemotherapy-induced febrile neutropenia, and risk factors for developing febrile neutropenia and the therapeutic outcomes. Mean age of the patient was 57. In all, 23 patients died due to complication related to febrile neutropenia. There was not a statistical difference in therapeutic outcome among tumor types, performance status, sex, department of neutropenia, or time from emergency department presentation initiation of antibiotic therapy. Age was an important prognostic factor for therapeutic outcome. Mean age of fatal case was 65 years versus 56 years for non-fatal cases. Mortality rate was higher in patients with blood culture proven bacteria than in those whose blood cultures yielded no organism. Median time from ED presentation to the start of antibiotic administration was approximately 2 hours. Further studies are needed to establish a more appropriate management strategy for chemotherapy-induced febrile neutropenia and reducing the incidence of mortality and morbidity due to chemotherapy. Intervention for Mary. She admitted to oncology ward, MSc was done, throat swab was done, reverse barrier nursing was started. She was in an isolation room. Continue antibiotic therapy, tazocin 4.5 gram TDS, gentamicin 400 milligram OD, normal saline started at 125 ml per hour. Outcome on day 3 was temperature still persists, but it was less than 38 degrees centigrade. Oncology team was contacted, repeat blood cultures taken, MSU shows NAD, and microbiology contacted, and they suggest tecoplanin 400 mg OD. On day 3, Mary became tachycardic at 130 beats per minute. Blood pressure drops to 80/40, and she was commenced on stat gelfusion, transferred to ICU. On day 5, she was stabilized in ICU, returned to ward, continued tazocin 4.5 gram TDS, add vancomycin 1 gram BD, blood cultures showed gram-positive cocci. On day 9, temperature was stabilized, continue IV antibiotic for 14 days and neutrophils were 0.2. Day 12, neutrophils reached 0.9. Day 14, IV antibiotic discontinued, commenced upon oral augmentin for 14 days, discharged home, public health nurse referral was sent. So Mary had unscheduled stay in hospital for 14 days including ICU transfer, psychological distress to Mary, her husband and her 2 children, delay in commencing cycle 3 chemotherapy. So nursing point of view, we need nurse education. Looking at delay in any department, best practice is nurse looking at febrile neutropenia risk assessment. Conclusion, Mary, 42-year-old lady diagnosed with stage 2 adenocarcinoma of the breast, received surgery and 2 cycles of chemotherapy. Post second cycle of chemotherapy, Mary developed febrile neutropenia. Inpatient hospital stay for 14 days, psychological distress on Mary and her family, chemotherapy dose delay, Mary finished her full chemotherapy regime, prophylactic GCSF, dose intensity maintained and went into remission. Thank you for watching.